Chapter 13, Bipolar and Related Disorders. These are formerly known as manic depression, which is a chronic recurring illness that is characterized by unusual highs and lows. So the clinical picture. Bipolar 1 disorder. It is the most severe form of bipolar and it has the highest mortality rate. Patients suffer from occupational and interpersonal difficulties, even if they are in remission. You have to have at least one manic episode, which is an intense duration of euphoria when the patient may partake in high-risk behaviors, have intensified energy, pressured speech, psychosis, and usually does not sleep or eat for days. This is a psychiatric emergency. The mania leads to agitation and irritability and then to exhaustion, in which the individual swings to the opposite end of the spectrum into depression, which can also lead to high-risk behaviors such as becoming violent or attempting suicide. You can see the criteria box on page 220. Bipolar 2, you have to have at least one hypomanic episode and one major depressive episode. It is the most common form of bipolar and is commonly misdiagnosed as major depressive disorder. So hypomania is a less intense or dramatic form of mania. Psychosis is never present with hypomania and it generally does not interfere with normal functioning. And then there's cyclothymic disorder. This is an alternate between mild to moderate depression for at least 2 years. There is a rapid cycling. It can be experienced with any of the bipolar disorders, and it is classified as at least 4 mood episodes in a 12-month period, and it is associated with more severe symptoms. You need to know the signs and symptoms of mania in all phases. So other bipolar disorders, you have substance and medication-induced bipolar and related disorders, and bipolar and related disorders due to another medical condition. Epidemiology, the lifetime risk is overall was nearly 4%. Men and women are nearly equal. There can be severe postpartum psychosis that puts you at a 4-time greater risk. With children and adolescents, they tend to be diagnosed with disruptive mood dysregulation disorder first. And with cyclothymic disorder, it begins in adolescence and early adulthood, and there's a 50% risk of a subsequent bipolar 1 or bipolar 2 diagnosis. So comorbidities. Nearly all anxiety disorders are associated with bipolar 1, which affects about 75% of people with this disorder. So panic attacks, social anxiety, and phobias. Other disorders may complicate clinical presentation and management of bipolar 1, such as ADHD. They're all disruptive, they're all impulse control or conduct disorders. And then there's substance use disorder is present in over half of those with bipolar 1 and also serious medical conditions. Um, 75% of individuals with bipolar 2 have comorbid anxiety disorders. They also have eating disorders, particularly a binge eating disorder, and they tend to have substance use disorders. Comorbidities of cyclothymic disorders. Substance use disorders are common, as well as sleep disorders. And ADHD is more common among children with cyclothymic disorder than with other mental health conditions. So biological risk factors. Genetically, there is a higher risk with first-generation family history. It is also shown to be more prevalent in those with high IQs, especially in children. Neurobiological, there may be chemical imbalances in norepinephrine, dopamine, and serotonin. Neuroendocrine, there is research into the hypothalamic pituitary thyroid adrenal axis, with research showing hypothyroidism as the most common cause of physical abnormalities. And then peripheral inflammation, this is at a higher risk during both manic and depressive phases. Environmental factors, there are links to childhood trauma or stress, and cognitive factors the ability to dismiss psychological theories due to advanced imaging capabilities. Early diagnosis and treatment are key to prevent suicide attempts, substance use problems, interpersonal relationship problems, and development of a comorbidity. Now, as far as mood, these patients usually spend more time in the depressive state than in the manic state, but we're going to focus on mania in this chapter. The patient's mood is unstable and can fluctuate from happy to energized to irritated to angry. The Altman self-rating mania scale can be used, and you can find that on page 224. As far as behavior, they can be very manipulative and they can be demanding. And we talked about splitting previously, so the staff need to be unified when they handle these patients. The patient may become distractible and start projects but never finish them. They can be grandiose and extravagant. And once the mania phase is over, the patient may be in disbelief at some of their behaviors and they do not remember them. Now, thought processes and speech patterns, specifically pressured speech, circumstantial speech, tangential speech, loose association, flight of ideas, and clang associations, which we refer to and defined in chapter 12. Grandiosity. These patients can be very grandiose. They may believe that they have special abilities or that they have great power. Thought content. Often the content is sexually explicit and they can become very vulgar. Especially when the patient begins to have delusions, because their delusions are going to be grandiose and persecutory. Now, cognitive function. They begin with a high level of functioning. Then they start to have cognitive problems and they even can go into a remission. So cognitive deficits correlate with their manic episodes, with the history of psychosis, chronicity of illness, and poor functional outcomes. And you can see assessment guidelines on page 226. Now, self-assessment you need to do because discomfort is common. And you can enhance your professional ability by sharing and acknowledging uncomfortable feelings with staff or nursing faculty members, collaborating with staff and nursing faculty, and sharing your experience with peers in a post-conference setting. Now, your nursing diagnosis, prevention of exhaustion is key during the manic phase. So giving them a private room in a quiet location is ideal, because the patient may easily become overstimulated. Other things are risk for injury, risk for violence, sleep deprivation, impaired cognition, impaired concentration, a self-care deficit, and impaired socialization. And you can see more on page 227 in table 13.2. Now, during the acute phase, it begins with the onset of manic or hypomanic episodes, and it includes preventing injury, maintaining stable cardiac status, maintaining hydration and tissue integrity, getting sufficient sleep, demonstrating thought self-control, and attempting no self-harm. Now, they will need a structure and they may need one-on-one supervision. Remember, safety is a priority not only for the patient but for everyone else in the room. During the maintenance phase, this phase involves preventing recurrence of manic episodes. So obtain knowledge of the disorder, management, and medication. Identify sources of support and attend group therapy on a daily basis, and problem solve by identifying new coping skills. Now, planning. During the acute phase, there should be medical stabilization, maintaining safety, in-hospital nursing care, and you may have to apply seclusion, restraint, or ECT therapy during this phase. During the maintenance phase, the focus is on preventing relapse, limiting severity and duration of future episodes. Patients with bipolar disorders require medications over long periods of time and over their entire lifetime, and support patients in repairing their lives from the hardships that came out of the acute phase of illness. Implementation. Treatment is often delayed by about 10 years due to feelings of ambivalence, so that's negative or positive symptoms, and substance abuse. Now, depressive episodes, they have the same symptoms as major depressive disorder, but they're more intense. And hospitalization may be necessary if the patient is suicidal or has psychotic or catatonic signs. Now, there are concerns about medication bringing on a manic phase, so medication should be used cautiously. Manic episodes, hospitalization for acute mania will be necessary to provide safety and stabilization. It is also important to educate the patient on community resources and outpatient facilities to help them develop strategies to overcome their challenges. And you can see this table on page 228, table 13.3. Communication techniques. Let's go back up. Don't think it's right in here. That's okay. Use firm and a calm approach which provides structure and control. Use short, concise explanations to minimize potential for manipulative behavior. Identify expectations in simple terms. Provide safety and give the patient understanding for treatment. If the patient has legitimate complaints, listen to them to reduce feelings of helplessness and minimize acting out. Firmly redirect them with distractibility, which is the most effective tool for mania. So implementation, focus on preventing relapse. Medication adherence is essential. They need regular and adequate sleep, healthy nutrition, community support, engagement with community resources, and use of outpatient facilities. Health promotion and teaching, we need to provide information on the recurrence of bipolar illness, warning signs of impending episodes, the importance of regularity in meals, activities, and sleep, and attending group and individual therapy. Now, teamwork and safety, there should be frequent staff meetings to deal with patient behavior and staff response, as well as all staff being consistent with limit setting. Seclusion and restraint, remember that this is a last resort, so there should be documentation of clear risk of harm to self or to others, the patient being unable to control action, and other measures that were attempted and failed. Support groups. There are several out there, as you can see on the slide. Evaluation. Evaluate your outcome criteria, reassess outcomes in the care plan, revise the care plan if needed. Long-term outcomes can be added in time. These can be adherence to medication regimen, resumption of functioning in the community, achievement of stability in family, work, relationships, and mood, and improved coping skills to reduce stress. So treatments. The two main foci for pharmacotherapy are to reduce agitation and stabilize the patient's mood. Patients are apt to not adhere to their medication regimen, so perform mouth checks after administering medication. Provide once daily dosing of medications if able, because this simplifies therapy and it makes it easier for the patient to be compliant. Use sustained release forms of medications because this requires less frequent dosing. Engage patients in conversation after administering meds because if they are talking to you, they are less likely to hide their or less able to hide their medications. All right, let's talk about lithium. The FDA approved lithium to treat acute and the maintenance phases of bipolarism. It takes about 10 to 21 days to work, but there is a very narrow therapeutic range. It is a very small window with maintenance levels of 0.8 to 1.2. The first level should be drawn 2 to 3 days after you initiate therapy, and then drawn with any dose change or at least every 3 to 6 months. You do need to watch your patients for signs of toxicity. On page 233, Table 13.4 is a very, very important table. And usually you're going to see signs of toxicity at levels of 1.5 or higher. And you notice that gastric upset keeps popping up. There are long-term risks with lithium that include hypothyroidism and kidney impairment. So you need frequent assessments on both. Now there are contraindications. This includes patients with cardiovascular disease, brain damage, renal disease, thyroid disease, myasthenia gravis, women who are pregnant or breastfeeding, or children under the age of 12. Lithium is not used as frequently because there are newer drugs with fewer side effects and a lower risk for toxicity. And on page 234, box 13.2 gives you patient and family teaching points. Now there are also anticonvulsants that are used to treat seizure disorders, but they're also approved for acute mania, acute bipolar depression, and or bipolar maintenance. So the first one here is valproate. This treats acute mania and prevents future episodes of mania. There is a black box warning with it, and it is important to monitor liver function and platelet counts. Next is carbamazepine, which is used to treat acute mania and mixed episodes. It is a second-line treatment due to drug interactions and side effects. You need to monitor liver enzymes and a CBC, and there is a black box warning for dermatological reactions. Lamotrigine is a maintenance medication used for those 18 years and up, and you need to discontinue it if a rash develops. There are also second-generation antipsychotics. These are used to treat acute mania, and also they have mood-stabilizing properties. You can see examples on page 234 because we've already talked about these with schizophrenia. Just remember that these second generations can cause extrapyramidal symptoms like your neuroleptic malignant syndrome. Bipolar depression can be treated by combining an antidepressant with a mood stabilizer, and this reduces the risk of the patient developing mania. Again, there are examples you can see on pages 234 and 235. So integrated therapy. You can give omega-3 fatty acids like cod liver or fish oil, but there are no evidence that supports using this to treat mania, but there is strong evidence that they may improve depressive symptoms. You also have your brain stimulation therapies such as ECT. This is most commonly used for patients with severe depression or bipolar that have not responded to other treatments. It does involve, as we've already talked about, a brief electrical stimulation of the brain while the patient is under anesthesia. And then there's repetitive transcranial magnetic stimulation. This has been approved for treatment-resistant major depressive disorder, but not for bipolar depression. This is a daily application of repeated magnetic pulses on certain areas of the brain. And then you have your psychological therapies, such as CBT, interpersonal and social rhythm therapy, and family focus therapy.